Bismillahirrahmanirrahim and Assalamu alaikum. I feel honored and privileged to speak in front of such an exceptional audience. So the topic of my talk is one of the most debatable topics or discussed topics, especially during the last decade in the field of cardiovascular sciences. And it is about the surgical AVR and TAVI. I have nothing to disclose and no any conflict of interest. I begin my talk with this verse of Holy Quran, وَأَمَّا بِنِعْمَةِ رَبِّكَ فَحَدِّثْ, and proclaim the grace of your Lord. और अपने रब की नेमतों का तज़किरा करो. So we will be, ladies and gentlemen, we will be reviewing this topic under the headings of the global burden of aortic stenosis, surgical AVR, a brief intro, a TAVI, brief intro of it, and then the trials and their results, comparing the surgical AVR and TAVI, and how do guidelines direct us on this matter, and finally we will take a deep insight on this matter. So the global burden of aortic stenosis is rising, increasing its prevalence from 46 per 100,000 in 1990 to 116 per 100,000 in 2019, and there is an estimate of potential doubling of this figure by 2050. And the non-rheumatic calcific aortic disease prevails and dominates in the West, with an estimate of about 13.3 million cases, probably due to the aging population. While in the developing countries, rheumatic heart disease prevails and holds the crown with as high as 54.8 million cases. The standard traditional treatment for terminal stage disease, surgical AVR, from its start in 1957 till date, millions of cases have been performed, and even today, 0.2 million cases are performed of surgical AVR worldwide. And the journey of this remarkable procedure has moved from the early complex open heart surgeries to the minimal invasive procedures now. The significant benefits of this procedure, which can be quickly mentioned, it is a time-tested procedure with a data based on more than 50 years. It is still the most potent method to deal the patients with less than 65 years of age. The valve durability is more, and the mortality is reported as low as 0.5% from many centers worldwide. And the beneficial and only choice in concomitant disease, when we are addressing the concomitant disease with aortic stenosis, it is the best choice. The TAVI, from its start in 2002 by Alain Caribert and his team in France, we have seen and observed a tremendous growth of this procedure during the last 2 decades. And we can estimate and observe the growth of this procedure that even in this year, annually by the end of this year, more than 100,000 cases are performed of TAVI in US alone, while the global estimate of the number of procedure is about near 300,000. And the procedure is being performed in over more than 700 centers in the world and more than 50 countries. The TAVI procedure differs in the types of balloon used, their frames and their deployment. They are either the balloon expandable or the self-expandable, and the sealing mechanism used to prevent the paravalvular leak. Either they are stented frames, or some modern valves may also have a polyester fiber or fabric outskirt to deal with the paravalvular leak. So there are so many valves used in this procedure. The Sapien series by Edwards Life Sciences, then the Evolved by Medtronic, and the Accurate Neo by Boston Scientific, and Portico valve and Lotus by others. And this figure shows the different types of commonly used valve in this TAVI procedure. This is a busy slide showing the landmark trials which have so far compared the TAVI with surgical AVR. Starting from the Notion 1 trial in 2015, as Notion 2 trial also came recently, it was the first trial which compared the surgical AVR, TAVI with surgical AVR patients. And then the famous partner series, the partner 1 is not written as it compared the TAVI with medical management. The partner 2A with the Sapien XT valve compared the patient with surgical AVR in intermediate risk, while the CERTAVI trial and then the most famous, the partner 3 trial in 2019 compared the TAVI with Sapien 3 valve with surgical AVR in low risk patients, and another adult low risk trial in 2019. What do the trial concluded? The trials concluded that the TAVI is now indicated at all risk levels of the patient. In intermediate, low risk and high risk patients, TAVI is indicated, and now considered on the basis of anatomy, age and the life expectancy of the patient. The trials concluded with TAVI having lower mortality than surgical AVR, having low risk of a stroke, low risk of major bleeding, low risk of new onset of AF. Patient had shorter hospital stay, they suffered lesser pain, and there was rapid return to normal activities. But TAVI was associated with higher major vascular complications, more cases of paravalvular leak, and more cases of PPM implantation post-procedure, and higher rate of valve reintervention. An interesting thing I like to mention is that the valve replacement durability data, which has been compared so far, is 50 years of surgical AVR with only 5 years of TAVI. And the mean age assessed, even in the latest trial, the Notion 2 trial, is still not less than 71 years. And in the partner 3, it was 73 years. So this is basically a procedure for the septuagenarian and octogenarian population so far. How do the guidelines direct us when we have to select a bioprosthetic AVR between the procedure of TAVI or surgical AVR? In the guidelines, only this point at number 3 prefers the TAVI over surgical AVR. And it says that patient, if more than 80 years of age and the life expectancy is less than 10 years with no contraindication, then the TAVI is preferred over surgical AVR. While at this point 2 guide us about the shared decision making between the surgical AVR and TAVI, between the age between 65 to 80 years of age, thinking about the durability of the valve and expected life longevity of the patient. Simplifying, this chart simplifies the guidelines. If the patient is less than 65 years of age, surgical AVR is the recommended treatment. If the patient is between 65 and 80, surgical AVR or TAVI can be considered with shared decision making. If then more than 80, then TAVI is preferred. And if below 80 and life expectancy less than 10 years, then TAVI can be considered, while the unsuitable anatomy patient goes for the surgical AVR, femoral anatomy. Now let's take a deep after this intro, let's take a deep insight on this matter. There is no doubt in it that this transcatheter therapy has revolutionized the AVR and has benefited thousands of patients over the last decade. And now it is acceptable at all risk levels and guided, as I earlier said, guided by the anatomic considerations, age and the life expectancy. And this paradigm shifted has resulted in an explosion of TAVI and obviously a decline in surgical AVR. According to the STS Adult Cardiac Surgery Database and ACC, TAVI registry. In 2012, around 10,000 procedures of TAVI were performed, and they have now escalated to near 300,000. Obviously, there is significant decrease in the number of isolated surgical AVR, as compared to 2012. In 2022, there is a 36% of decline in the patients in the procedure of surgical AVR. And according to our data, only 18 cases per surgeon in the US in these years. One question comes in our mind, that is this change evidence-based and guideline-driven? But the data demonstrates that the decline in surgical AVR is not necessarily a guideline-driven practice. There is a substantial indication breach has been identified, such that TAVI is being preferentially used in the two populations that were not included in the comparative trials between the TAVI and surgical AVR. And if they were included, they were in very small number. Yes, I am talking about the bicuspid aortic valve population and the age less than 65. And despite and against the guidelines, more than 50% of the patients in the US are presently being treated with TAVI as opposite to surgical AVR. A cohort study, observational study of 2,000 patients who underwent TAVI in less than 65 of age showed a higher mortality of 27% as compared to 15% with surgical AVR. The younger patients who undergo TAVI had a higher mortality. In addition, the Medicare registry claims that a similar data has been demonstrated in the bicuspid aortic valve patients who undergone TAVI. They had a higher mortality rate, higher rate of stroke, and more valve reintervention rate. Even more recently, in 2025, the Notion 2 trial says that the TAVI showed a significant higher risk of adverse outcomes in patients with bicuspid, indicating a need for caution with this patient group. After these findings and higher mortality in the patients with bicuspid aortic valve and age less than 65, and any increased penetrance of the procedure in these patients, we should consider a moment of pause. Are we considering the appropriate therapeutic application of transcatheter aortic valve technology? Furthermore, if I move forward, there is an false inherent assumption has been made that a patient receiving a TAVI would not be an operative candidate in future. But dear sir, this paradigm has shifted now. The cardiac surgery after TAVI is now the fastest growing operation in the STS database. And between 2012 and till 2023, more than 5,000 patients who previously underwent TAVI underwent cardiac surgery later on. And so the frequency of cardiac surgery after TAVI as compared to 2012 has increased more than 100%. And the 30 days mortality in these patients who underwent TAVI, who underwent cardiac surgery after the TAVI, they had a 30-day mortality of 15%, which is far greater than the predicted existing STS risk models. So the assumption that cardiac surgery after TAVI is safe and comparable to cardiac surgery without previous TAVI is now misguided. Given this new evidence, patient may be, if the patient is of reasonable and low operative risk initially when TAVI was being considered, should be carefully evaluated for surgical AVR by the heart team discussion. Even the new STS risk calculator designed to address these patients is now available online. With this, I conclude myself. TAVI unquestionably is one of the most successful recent innovations in cardiovascular era. But currently, it seems that the application of this cast catheter technology has crept forward of its existing evidence-based medicine, especially in the context of excellent results of surgical AVR and the high risk of mortality of cardiac surgery after this procedure. Let it be a surgical AVR and TAVI, not surgical AVR versus TAVI. Let's make it a synergy. We look forward to work collectively with all stakeholders as we design and implement future studies in this space, which will continue to inform our patients of the shared decision-making process around the therapeutic intervention for aortic valve replacement. I am grateful for your presence. Thank you.